Welcome to another installment of the 5 things you need to know from the AUA. My name is Max Cates. I'm director of the Division of Urologic Oncology at the Brady Urological Institute. And today we have Dr. Armine Smith, who is the director of urologic oncology at Sibley Memorial Hospital. And she'll be talking to us about the 5 things you need to know in bladder cancer from the recent AUA meeting. Dr. Smith, take it away. What are your 5 things? And then we'll jump right in.
Sounds good. Hi, Max. Thanks for having me. I think there was a lot of excitement this year at the AUA in the bladder cancer realm. So some of the things I wanted to point out were the new drugs that were presented at AUA 2024. I want to talk a little bit about the 3 newish FDA-approved drugs for the non-muscle invasive bladder cancer. Talk a little bit about some surgical advancements in the field. The EV-Pembro data, which is for the muscle invasive bladder cancer category, and then some of these more futuristic categories such as biomarkers and the AI integration in our practice.
That's wonderful. So let's jump right in. So, one of the things you mentioned was NMIBC drugs, and specifically some clinical trials that have begun to read out. So it sounds like the first thing we need to know is that the landscape of BCG unresponsive bladder cancer is changing with these new studies that have reported out. Do you want to talk a little bit more about the data of CG and TAR-200?
Yeah. Well, again, like I said, a lot of excitement there. I don't want to give away my age, but when I started, practicing treatments of bladder cancer, it was a very different landscape. It was like BCG was approved in 1976 and started being used in 1976, and there was like a huge hiatus. But we had actually 3 trials presented at the AUA this year with the newer drugs. One was the TAR-200. The other one was the cretostimogene, which is the BOND-3 trial. And then we had some early results from the EG-70 trial, or the, I believe the trial is called Legend. The TAR-200, and I'll go a little bit into the background, is, as we lovingly call it, the pretzel. It's the one that's being used that's impregnated with the gemcitabine, and it provides a slow release of gemcitabine in the bladder when it's stalled. The nice thing about it is it's office procedure, so it's put in the bladder by urologist or a mid-level practitioner, and it's given as a induction, which is every 3 weeks, followed by maintenance every 3 months. So the data that the Sunrise 1 trial presented was from the cohort of the patients who were just given the TAR-200 alone without any combination. And this were patients who failed BCG, so they had either recurrent disease or unresponsive disease. They were given as an induction, and no reinduction was allowed, and they were followed by maintenance. The response was quite good at 85% at 3 months, 76% at 6 months, and 62% at 12 months. And it was fairly well tolerated, about 4.7% discontinuation for adverse effect related toxicity. So this medication was given FDA breakthrough designation. The second trial that was presented was the BOND-3 trial, and this is a cretostimogene. I mean, my only criticism of all these drugs, I feel like the names are getting more and more complicated to pronounce, but other than that, very little criticisms. So the creto is a E2F promoter kind of a driver. It's a conditional replicating adenovirus gene. It's given intravesically. It turns on, the cycle that promotes a tumor lysis, mostly RB pathway deficient tumor cells, but, other tumor cells as well. And the BOND-3 trial was a phase 3 registration study. It reported on cohort C, which was BCG unresponsive CIS, which also allowed papillary disease, and the papillary disease had to be completely resected. The medication was given as 6 intravesical installations sequentially, weekly, And it was followed by either repeat induction or maintenance. And the maintenance was given kind of in like the SWOG BCG type of a regimen. It was 3 months apart and then 6 months apart. The data reported was about 75% complete response at any time, and 53% of patients with repeat induction converted to the CR. And it was fairly well tolerated with very low discontinuation due to adverse effects. So the company is also running multiple other trials. It's running a trial for intermediate risk disease for BCG naive cohorts. So we'll have more data coming our way from this. Also, another early result was from the EG70, which is a non-viral intravesical gene. Also stimulates a cytokine release and the overproduction of IL-12. So Legend reported on the phase 1 and 2 combination trials. So the phase 1 was looking at the safety and 3-month outcomes. Phase 2 was more of a 12-month outcomes and continued kind of tolerance. The anytime response was about 73%, broken down to 68% at 3 months and 45% at 6 months. However, when they looked at the preliminary data for the dosages that were selected for the phase 2 trial, the numbers looked a little bit better. So the CR was about 70% at 3 months and 60% at 6 months. So a lot more to come from these companies.
So if the first thing we need to know from the AUA is that there are these exciting trials, 2 of the trials you mentioned are FDA registration trials, I believe. So, that means that, in the next year or 2, we could see those drugs actually be approved and come to market. And that's on the heels of the second thing we need to know from the AUA, which is that for BCG unresponsive disease, there are now 3 new, and I say new in the last 3 years, FDA approved therapies. Do you want to talk a little bit more about that and sort of what that means for the field of early stage bladder cancer? Because it's really, as you said at the outset, a major change.
Yeah, it is. And I think, we might be in a position where we have too many choices actually to pick for these patients, which is, not a bad problem to have. But looking back at, the first FDA approval for non-BCG, drug for BCG failure was pembrolizumab, which was in 2020. This was based on the Keynote 57 result. We all know pembrolizumab is a CPI, so immunotherapy agent. This was based on a complete response 40% anytime and durability of the response about 46% at 12 months. Unfortunately, the durability kind of dwindles over time. So a longer data showed only about 20% durable response after 2 years. On the heels of this approval was the natafaragene, which was approved in 2022, or it's Adstiladrin. It was also based on the NCT trial. The complete response was reported 51% anytime, 46% durability of response at 12 months. And it was fairly well tolerated as well. They had an update at the EAU meeting of 2024 with the durable response past 3 years was 26% at CIS group and 31% at papillary group, which is, not a bad number. And for some people, it allows them to avoid cystectomy, which is great. The N803 was approved in 2024. I believe it's pronounced nogapendican. It was based on the QUILT 3.032 trial, and this medication is a little bit of a different class of drug. It's an IL-15 superagonist. It was given with the BCG, and CR was fairly good. It was 62% anytime. Durability of response was about 58% at 12 months. And we'll find out, longer data will show us how much longer this is going to last. Again, well tolerated, only 7% of patients discontinued their treatment because of the adverse effects.
So, taking the two top end things we need to know in bladder cancer from the AUA, basically the field of non-muscle invasive bladder cancer is changing before our eyes. It sounds like we have 3 new FDA approved drugs. It sounds like we may have 2 more at least coming down the line in the recent, in the near future. And so the challenge for the practicing urologist is going to be understanding how to sequence these drugs, when to take a patient for cystectomy to avoid progression, how to understand toxicity of these drugs, and how to understand toxicity to the bladder. So it's amazing that even as we improve, hopefully, the lives of our patients with these new drugs, it's going to open up many more questions and in many ways make the care of early stage bladder cancer a little bit more complex as it gets a little bit better.
Mhm.
So let's keep going for the third thing we need to know, which is developments in surgical care. Can you tell us a little bit about both for resections of bladder tumors as well as at the time of cystectomy, some of the some of the things that came out of the AUA?
Absolutely. So some things that stood out to me during this AUA was data reported on a en bloc resection of bladder tumors, which kind of has been discussed before at our prior meetings. And this, what it is, it's really just, instead of going in and shaving off the tumor in pieces, you want to try to remove it by carefully kind of encircling it and removing it as a whole. It helps the pathologist to kind of have the orientation. It gives you a better idea of what's the deepest part of the tumor and what's the superficial. So this year there was a report of a single center but a randomized trial comparing en bloc resection with the conventional TURBT. They selected the patient with tumors less than 3 centimeters, less than 3 tumors per bladder, and no sign of extravesical or advanced tumors. They've compiled, I believe, a cohort of about 218 or 220 patients, and they followed them for significant amount of time, looking at the recurrence-free and the progression-free kind of data. This was designed as a non-inferiority trial, and it proved to be just that. En bloc resection was non-inferior to the conventional TURBT when followed for both the risk stratification of the disease and the grade of the disease. So I think fairly kind of good message. Based on this, I don't think we would go and change the way we do our resections, but if you pick a resection style and continue with it, it makes compelling evidence that we can continue practicing the way we did. Now, the second one that was also quite exciting was the randomized trial from the SWOG S1011 trial. And this one was comparing the extent of the lymph node dissection for the muscle invasive disease at the time of radical cystectomy. So, this goes back to kind of years of doing resections in the pelvis versus going a little bit outside of the pelvis into the distal IVC and the distal aorta area. And I think, this was a very nicely designed trial, looked at the disease-free survival as a primary outcome, but they also looked at the overall survival and some of the complications that may have been associated with either of these techniques. So they had about 592 patients randomized to 2 arms. One arm was the standard pelvic lymph node dissection, which included the internal and external iliacs and obturator nodes. And the extended pelvic lymph node dissection also added the presacral lymph nodes and the distal IVC and the distal aorta lymph nodes to this template. It was a 6-year follow-up, so quite long, but it was very well balanced with the randomization. About 30% of patients had advanced disease, T3 and above, and about 60% or 57% of the patients had neoadjuvant chemotherapy. The disease-free survival and overall survival was similar in both groups, which was quite interesting. There was a little bit of advantage of standard pelvic lymph node dissection had decreased mortality in 30 and 90 days. and had a little bit of a higher recurrence in the local pelvic area in the node-positive disease, which was as expected. But again, the disease-free survival, overall survival over 6-year duration was fairly similar in these patients.
Yeah, that's a fantastic review of two aspects of bladder cancer care, en bloc resections at the time of management of non-muscle invasive bladder cancer, and then lymph node dissection during cystectomy for muscle invasive. So even surgical trials are possible, and they're changing how we surgically manage these diseases.
Mhm.
Let's move on to the fourth thing you need to know, which is really something that has changed the face of bladder cancer care, and that's the reporting out of the EV Pembro data for metastatic cancer, and how what are the implications of that for our bladder cancer patient and the practicing urologist. So can you speak more about that?
Yeah, no, the EV Pembro data that was reported out at ESMO, it was really a breakthrough finding for a lot of us. And the combination of enfortumab vedotin and the pembrolizumab has become pretty much the winner in kind of the metastatic and a muscle invasive disease group category. So if anybody doesn't know it, EV is the antibody drug conjugate, which links Nectin-4 antibody to the drug of choice, which is the monomethyl auristatin. It's a microtubule disrupting agent. It's internalized. It causes fairly good, tumor lysis and cancer cell death. There were a few different trials looking at the EV alone and the EV with the pembrolizumab. The keynote or EV302 trial was an open label randomized trial. It was evaluating EV in combination with pembrolizumab versus chemotherapy in patients who previously were untreated, but had either locally advanced or metastatic urothelial cancer. The results were just amazing. The EV Pembro had overall response of 67% compared to 44% in the chemo group. And the complete response was also doubled. It was 29% in the patients with the EV Pembro group versus 12.5. The advantage of the EV Pembro, and it's being tested in a multitude of other trials or, additional cohorts of this trial, looking at the patients who are cisplatin eligible, given in the neoadjuvant setting or given in the adjuvant setting after radical cystectomy. So all of these will report out. But again, it's a game changer because patients will not be excluded based on the kidney function, which sometimes is really a determining factor for a lot of our patients before cystectomy or even for the local cancer, metastatic cancer treatments.
Yeah, that's fantastic. And I think that the urologists out there are going to see more and more EV Pembro because it was so successful in metastatic bladder cancer that there's so many studies now evaluating it and around the time of cystectomy for muscle invasive disease and even earlier. So important to know about it now and in the future.
Yeah, and I think the other thing we're going to end up kind of having to figure out is if these patients have these amazing complete responses, who are we going to able to spare the bladders on? So that's going to create a lot of kind of other, studies for us to look into.
That's exactly right. Consolidation, this idea of cytoreduction is obviously not new to urology, but it's relatively new to bladder cancer. And so it's actually very exciting and a little scary that we don't have much data on when and how to consolidate with bladder removal in patients that do well from systemic therapy, because in the past they haven't done well, and now they are. And so it is changing the game and bringing on new questions. Okay, let's go to this last one, which is arguably the most futuristic, but the future is now. And so you list the fifth thing we need to know in bladder cancer from the AUA as liquid biomarkers and AI-based testing. Can you tell us a little bit more about that?
Yeah, so the liquid biomarkers are kind of the holy grail of, I guess, bladder cancer, right? Because it's something that will eventually avoid cystoscopies and all this morbidity we give our patients in the surveillance of the bladder cancer. And this is not a quite brand new concept, I would say, but it's been kind of being developed over the past few years. So one of the most robust data we have are coming from Convergent, who has the URAMP minimal residual disease assay. So they've reported out in 2023, and they've reported out again in 2024 in conjunction with other kind of treatments that are given in non-muscle invasive bladder cancer. So what this assay is pretty much a ability to detect tumor DNA in the urine of the patients. And, they're able to identify all single nucleotide variants, copy naming variants, insertion, deletion. So a whole variety of genetic mutations. You can pick those up in the patients who have the tumor, and you can follow them as they're getting treatment and engage the response based on that. So one of the trials that looked at the URAMP this year and reported out was a combination of this methodology with Adstiladrin. And they had a fairly interesting report showing that post-treatment urinary minimally residual disease status was highly predictive of future recurrence. So patients who did not have any genomic DNA circulating in their urine after the treatment did not have recurrence. So I think, again, more data to come. It's going to be used in a lot of different studies, and hopefully this will be one exciting development to look forward to. We have a few more companies that are advancing their data in this field. Yeah, and they had some of the trials, but again, we're hoping to get some robust data from them. Now, as far as the AI, it was an interesting report from the Valar Labs that looked at a computational histology with AI, trying to gauge biomarkers for response prediction in bladder cancer, again, non-muscle invasive. This was a multi-center large trial, looked at over 1,000 patients. They looked at the tumor itself, the aggressiveness, mitotic rate, the grade of the tumor, also microenvironment characteristics, including immune infiltration. And they've, based on a lot of the data that was put in, they were able to classify these cases into high risk AI and low risk AI. And they also looked at sometimes called a BCG unresponsive biomarker, BUB. And when they looked at the results from all these patients, patients in the high AI group had significantly inferior response rates and progression rates versus the low AI group. They also felt that BCG unresponsive status was more likely to be picked up with this technology as well. So, this is as futuristic as it gets for the field of urology.
That's for sure. This was a fantastic list. I hope our listeners are appreciating that. Bladder cancer is changing before our very eyes. Yesterday's news is ancient. Today's news is already in the past. So thank you, Armine, for speaking to us about what was going on at the AUA and bladder cancer. Please stay tuned for future episodes of the top 5 things you need to know from the AUA.
Thank you, Max.